Good morning, good afternoon, and good evening, depending upon which part of the globe you are presently. This is the International Society for Coronary Artery Surgery, a webinar devoted to the topic of the ACC AHA SCAI Revascularization Guidelines. The mission of the International Society for Coronary Artery Surgery is to advance the state of the art in surgical coronary revascularization and to improve the care of patients with coronary artery disease. We're privileged to have with us today cardiologists and surgeons who were co-authors of the recent ACC AHA guidelines. In particular, Jackie Thomas-Holland is co-chair for cardiology, and Dr. Creighton Don and John Biddle are attending. Dr. Don is attending from California, where it's presently 5 a.m. He may win the prize for most dedicated attendee. Surgeon co-authors of the guidelines also in attendance today include Dr. Freems, Dr. DeMaio, Dr. Selke, Dr. Zwischenberger, Jennifer Lawton, who is the co-chair, and Mario Gaudino. As we all know, there's been a recent publication from surgeons representing STS and AETS related to these guidelines, and that position will be represented by Dr. Mark Moon, past president of AETS, and Dr. Mark Ruel, a present STS board member. The International Society for Coronary Artery Surgery Board of Directors are in attendance, and they're all presented here. Dr. David Taggart and I founded the International Coronary Congress 8 years ago, and we've recently spun off now our parent organization, the International Society. We're privileged to have these important members of the surgical community and cardiology community as members of the board representing different geographic areas of the globe. Dr. Farku is Director for Cardiology. You will remember him as first author of the Freedom Trial. Dr. Arai from Asia, Shengshu Hu from China, representing the Fuwai Medical Center, the largest cardiac surgical center on the globe. Dr. Volkmar Falk, a prominent European surgeon. Naresh Trehan, representing the country of India, which, by the way, performs more coronary surgery than any other nation on earth at present. Dr. Stephen Freems and Dr. Bruce Lytle need no introduction. They represent North America, and Dr. Walter Gomes from Brazil, representing South America. I have the privilege of serving as the president of our society and will serve as moderator today. Our agenda is straightforward. We'd like to have Dr. Thomas-Holland present the guidelines in 10 minutes from the perspective of a cardiologist. Dr. Lawton will present the guidelines from the perspective of a surgeon. Doctors Moon and Ruel will share 15 minutes to present the position paper authored by STS and AETS, and then we'll have a moderated discussion of the points of contention raised and try to seek the right path forward. These ground rules are important, and I warn you that I have the mute button. We will ask that all participants express their opinions and viewpoints clearly and professionally, supporting their statements with data and evidence. We do not expect that everyone will agree on every point or even any point, but we do expect absolutely that everyone will express themselves professionally and collegially, scrupulously avoiding any personal attacks or unprofessional remarks. Please note this webinar is being recorded and will be posted live on the SCAS website for public viewing. So without further ado, I'm delighted to welcome my colleague and friend, Jacqueline Thomas-Holland, to present in 10 minutes the guidelines from a cardiologist's point of view. Dr. Thomas-Holland.
You're on mute, Jackie.
Dr. Holland, you are muted.
Yep, I see. Okay. Sorry. Sorry. Okay, can you hear me all? Okay.
Yes, we can. Very well.
Great. So welcome, everybody. Thank you, John, for giving me this opportunity to be part of this incredible panel. I'm really excited to be able to present the 2020 coronary revascularization guideline, my perspective from a cardiology viewpoint. For those of you who don't know me, I'm an interventional cardiologist at Mount Sinai Morningside. And as John mentioned, I had the privilege of serving as vice chair for this document. I also wear two hats. I was the joint committee liaison, and I'm a member of the ACC-AHA Joint Committee for Clinical Practice Guidelines. And so with that in mind, I'd like to just sort of spend the 10 minutes a little bit reviewing the guideline writing process, and then basically discussing from a cardiologist viewpoint what I felt were the most important take-home messages or new recommendations from the guideline. So the ACC-AHA really pride themselves on producing comprehensive, evidence-based, balanced documents. And they take a great deal of time and effort to be sure that there's no potential outside influence from industry. They require that over 50% of their writing committee members are free of any relationships with industry, and the chair of the document also has to be free of any relationships with industry. They also require that anybody voting on a particular reference must also be free of any relationship with industry. So you can vote on many different recommendations, but if you have a relationship with industry with respect to a said recommendation, for example, if you have a relationship with AstraZeneca and you're talking about ADAPT recommendation, you cannot vote on that particular recommendation. They also really want to ensure that the writing committee is very diverse, so geographically diverse in terms of gender, ethnicity, race, and important, we really wanted to be sure we had a balanced writing committee, particularly for this document. So we ensure that there were an equal number of interventional cardiologists and surgeons on the committee, and the remaining writing committee members were composed of nurses, anesthesiologists, cardiologists, and other such professionals. We really focused on having a consensus-based document. For 1 year or over 1 year, we met each week for 1 to 3 hours at a time to discuss each recommendation. And as a consensus, we reviewed all of the evidence. We discussed the recommendation, and as a group, we came to the decision about what COR and level of evidence we would give each recommendation. Then we met at a consensus conference right before the pandemic, and we spent 2.5 days reviewing the entire document again and reviewing every single recommendation. We then had to vote on all of these recommendations and sign off on the final document before it went to peer review. Once it went to peer review, when it came back, it was reviewed by many reviewers and many societies. We had over 500 review comments and recommendations. And we went back, we changed the document, modified the document, and modified recommendations. And then we went ahead and asked the writing committee members to re-vote on any changes and sign off on the final document. So I hope that you can see that it's extremely comprehensive, evidence-based, balanced, and consensus-based. So what I'd like to talk about now are the take-home messages from a cardiologist perspective. And first and foremost, you can see that this document is patient-focused. And in the very beginning of the document, we stress this right up front. The ACC and AHA really want all of their guidelines to be patient-focused. The scope of the document is no longer on a procedure. This is why we combined PCI and CABG prior guidelines into one document, because it's about the patient with coronary artery disease and how best we may be able to serve this patient. We really want to be sure that we have equity in care and that we include the patient's decisions, important beliefs, and they're part of the shared decision-making process. But as importantly, because this is about the patient and we are their doctors serving them, they really emphasize the use of the heart team in situations in which the best approach to revascularization is not clear. So really, again, getting together as physicians caring for this patient, understanding their clinical presentation, their symptoms, their anatomy, and deciding on the best approach to care for this patient based on their beliefs and based on their clinical presentation. So now let's move on to acute coronary syndrome. So in terms of the document, there has been very little change in the management of acute coronary syndromes because most of the stuff is from prior documents. There hasn't been that much change, but there was a whole new focus on managing non-infarct artery disease. Prior documents didn't give a whole lot of emphasis on what you do in patients with STEMI who have non-infarct artery disease, and about 50% of our patients with STEMI have non-infarct artery disease. So because of more recent data showing that there is some advantage to performing PCI, we provided a class 1 recommendation that in patients who have non-infarct artery disease that is supplying a large area of myocardium at risk, and in whom PCI is an appropriate approach, that PCI should be performed as a stage procedure. But importantly, and as a cardiologist, I see a lot of patients with really complex non-infarct artery disease. And so we as a group created a new recommendation saying that in patients with complex non-infarct artery disease, CABG is a reasonable option for the treatment in an elective fashion of the non-infarct artery disease in patients with STEMI. So you do the primary PCI with a PCI, and then at a later date, you would do elective CABG. And that's a new 2A recommendation. Now let's talk about the role of revascularization in stable patients. So what we did was we modeled our approach to prior documents, which always looks at the role of revascularization to improve symptoms or improve survival in patients with stable disease compared to medical therapy. And so as in prior documents, we demonstrated, or we gave strong recommendations for CABG in patients with LV dysfunction to improve survival compared to medical therapy, and for CABG in patients with left main disease as well as a class 1 recommendation. In patients who undergo PCI for left main disease, if you can achieve an equivalent result as that which you would get with CABG, then PCI in non-complex left main disease is a 2A recommendation to improve survival compared to medical therapy. But then we went on to look at patients with triple vessel disease, and we really reviewed the data in entirety, looking at the data from 40 years ago, the pivotal trials, and the data over the last 10 years, looking at subgroup analyses of the Barry 2D trial, looking at meta-analyses, looking at the ischemia trial, and the totality of all of the evidence. And after looking at all of the data, and if you take it true to the word, the literal word, improving survival, as prior documents have done, you can see that the data is not as robust as taking the totality of all of the evidence as originally thought if you use the literal word improving mortality, improving survival. And so we came up with a recommendation that CABG may be reasonable. It's still something that should be considered in patients who have triple vessel disease to improve survival compared to medical therapy. But the role of PCI is uncertain to improve survival compared to medical therapy. The big thing is that as a cardiologist, most of our patients really don't always care. I mean, they obviously want to know they're going to live longer, but if they're 85 years old, they really want to know, are they going to be coming back with more disease? Are they going to be coming back to the ER with a recurrent infarction and other events? And so we recognize that in patients with multi-vessel disease, revascularization is beyond just improving survival. And that in the ESC, the ACC, AHA, the guidelines have always focused on survival, but we realize that it's about reducing cardiovascular events. So our document provides a new 2A recommendation to say that in patients with multi-vessel disease, revascularization is indicated to reduce the risk of recurrent cardiovascular events. And this is a deviation from prior guidelines that looked only at survival and looked only at symptoms. So I think that that's really exciting for me as a cardiologist because there's a new indication for whether we would proceed with revascularization. So what about the preferences on the mode of revascularization? Well, as we said, we talk about when we should be revascularizing. And then the next question is, if we're going to revascularize, and if CABG or PCI is equally possible, what is the best role? And so we have a whole section looking at the mode of revascularization. And as in prior documents, of course, in patients with complex disease, complex left main disease, or complex triple vessel disease, CABG is recommended in preference to PCI to improve survival. However, we also looked at the role of diabetes in patients, the role of revascularization in patients with diabetes. And even though prior documents discussed diabetes, there were no formal recommendations in prior documents regarding which one to choose. And so we have a new recommendation stating that in patients with diabetes have multi-vessel disease, and if you can put a limit to the LAD because they have involvement of the LAD artery, that CABG is preferred to PCI to improve mortality. And this is really important because we have a lot of patients with multi-vessel disease and diabetes. And as an interventional cardiologist, I think we all need to take a step back and recognize that diabetic patients with diabetes really do better with surgery, and put this first and foremost as a class 1 recommendation is important to us as cardiologists. What about PCI? Well, we talk about radial access. It's now a class 1 recommendation that radial access should be performed. In ACS patients, we really recommend it to improve cardiovascular events and reduce the risk of bleeding. And in patients with stable disease, it's been shown to reduce the risk of bleeding. Again, we have to temper that with the potential risk for needing radial artery access if you undergo CABG. And we've emphasized that in our text, that if you're considering CABG, you need to really be sure that if you're going to use radial artery access, you use the non-dominant arm. You use the dominant arm for the radial artery access, so the surgeons can use the non-dominant arm if they need it. And finally, duration of DAPT. I know I'm out of time. I'm just going to briefly mention that there's new data looking at shorter duration of DAPT followed by P2Y12 monotherapy. And so we have new recommendations saying that you should consider as a 2A, it's reasonable to use a shorter duration of DAPT followed by P2Y12 monotherapy. And so in summary, these are my perspectives from a cardiologist's viewpoints. The document is extremely extensive, and there's a lot more than just what I just mentioned. And I hope you take the time to look at the document in entirety. There is an executive summary if you don't have time to read the entire 150-page document. So thank you very much. And I'm really excited to take any questions about this when we get to the discussion part. Thanks.
Tremendous, Dr. Thomas Holland. Thank you very much. And you just about kept on time, covering an immense amount of material. Jennifer Lawton served as the surgical co-chair of these guidelines and has the next 10 minutes to describe the document, the work product of the group from a surgeon's perspective. Dr. Lawton.
Thank you so much, John, and for the ISCAS board for inviting me today to talk about this tremendous guideline that Jacqueline did an amazing job introducing. Here's a picture of one of the publications. As Jacqueline mentioned, this has been a labor of love. My invitation to be the chair of the committee occurred in December of 2018. And we were somewhat delayed in for many reasons over the course of the development of the guideline, but it was published in 2021, as you know. And Jacqueline nicely summarized all the things that we went through: weekly meetings, voting, revoting, revisions. And so it has been a labor of love. The American Heart Association and American College of Cardiology guidelines, we know, are robust. They have rigorous standards, they have external validity, and they're based on collaboration. Tor Sunt in an editorial stated, those who synthesize them bear a considerable burden to be thorough in their research of the data and balanced in their interpretation. And that, as a writing committee, that is what we would strive to do and did strive to do. The ACC and the AHA have been working together since the 1980s to produce guidelines. And the foundation is for the delivery of quality cardiovascular care and to improve the care of the patients and align with the patient's interests. They are intended to define practices meeting the needs of patients in most, but not all circumstances, and should not be replaced by clinical judgment. And I think it's important to remember that as we discuss the new guidelines. You may know that the Institute of Medicine came out with a document, Clinical Practice Guidelines We Can Trust, and they list the ACC-AHA collaboration multiple times because they are characterized by long histories of development. They devote significant financial resources to underwrite this, and they have comprehensive reviews, carefully draft guidelines, and promote their implementation. And they also have a manual of methodologies and policies that you can look at if you're interested. As Jacqueline mentioned, the writing committee was very diverse, and I was privileged and honored to work with an amazing group of diverse people. And with such diversity and collaboration, we have unique views, intense discussion, debate, collaborative ways about coming about consensus in many of these guidelines. Importantly, we also had 2 patient representatives who helped guide us when we might have been in the heat of the battle, if you will, discussing guidelines, and brought us back to the perspective that this is really about the patient and what the patient needs. And I would be remiss if I didn't recognize Lorraine and Tom from the AHA staff, who have really pushed this through to the end and did an amazing amount of work. Jacqueline mentioned relationships with industry, and as she mentioned, I had to be without any relationships and more than half the committee did, and we went over this every single meeting. The guideline is intended to consolidate many of the previous guidelines with a patient-centered approach. So you'll see when you read the guidelines, they have a patient-centered statement, and these guidelines combine many of these previous guidelines. You all are familiar with the class of recommendation, which is benefit versus risk, which is entirely independent of the level of evidence. So what's new? There are 17 class 3 recommendations and 53 class 1 recommendations. Jacqueline mentioned the top 10, which is listed at the very beginning of the guideline. If you don't want to read the full document, you can get a brief summary with the top 10, which are listed here. And at the end, there's a list of things that we weren't able to make guidelines for. There was just not sufficient evidence. And the executive summary is also a brief description. So the first recommendation is new. It is to improve equity of care in revascularization. And it's a class 1 recommendation. And we felt it was so important we put it first, that in patients who require coronary revascularization, the treatment decisions should be based on clinical indication, regardless of age, sex, race, or ethnicity, and that efforts to reduce disparities are warranted. The second most important in order of recommendations in our document is to have shared decision-making and informed consent. 2 new class of recommendation. 1, guidelines that patients undergoing revascularization should have patient-centered discussions, listening to their preferences and their goals. And once again, the patients on our committee brought us back to this many times, and that patients should be given time to make informed consent and have decision-making. And with such in mind, you will see one of the figures in the guideline is revascularization in patients with stable ischemic heart disease. The majority of this figure is things that we would discuss with our patients when we're talking about coronary revascularization to improve survival. So the patients say to us, I want to go back to work tomorrow, or will this prolong my life, or will it take away my chest pain, or will it prevent me from coming back for more repeat revascularizations? And what we can see in the 2 yellow boxes, one on the far left and one on the far right, are revascularization guidelines, not to improve survival, but on the left to improve symptoms, class 1 recommendation for revascularization, separate from survival. On the far right, a 2A recommendation, which Jacqueline mentioned is new, revascularization to reduce cardiovascular events, 2A. So when a patient asks, we can tell them, yes, we'll improve your symptoms, we'll reduce cardiovascular events. But if you want to have improved survival, we have to focus on the rest of what's on this slide. Do they have left main disease? And we know complex left main disease, class 1 recommendation for CABG over PCI. Without the ability to perform CABG, we need to have a heart team discussion. For low complexity left main disease, in the middle, you can see a class 1 recommendation for CABG and 2A for PCI. You may be familiar with the European guidelines. Low complexity left main disease for PCI in their guideline is a class 1. On the right of the slide, multivessel disease for anatomy suitable for PCI or CABG, we then see stratification by ejection fraction. In patients with a normal ejection fraction, revascularization to improve survival in patients with normal ejection fraction, 3-vessel disease, CABG may be reasonable. In PCI, the data are uncertain. And on the bottom middle, you can see patients who have reduced left ventricular ejection fraction. CABG is a class of recommendation 1 for low EF, and for moderately low, a 2A recommendation. So there are also new recommendations, as Jacqueline mentioned, for STEMI and non-ST elevation acute coronary syndrome. The new recommendations are highlighted in red here, and they're both 2A recommendations. The top for STEMI, CABG, is reasonable to reduce cardiovascular events in patients who have STEMI after successful primary PCI, when they have complex multivessel disease. Down below, for non-ST elevation acute myocardial infarction, revascularization prior to hospital discharge after initial stabilization in patients, 2A recommendation. And on the left, guidelines for stable ischemic heart disease to improve survival, class 1 recommendation in patients with complex disease and diabetes, CABG is preferred over PCI. And other new recommendations, 1 for DAP non-adherence and in-stent restenosis, CABG 2A, and I'll go over those in a little bit more detail. So complex disease. The guiding principle on this slide, CABG improves survival compared to PCI in patients with left main and complex CAD. The first recommendation listed here, class of recommendation 1, to improve survival. Significant left main disease, high complexity, CABG is recommended over PCI. Second recommendation 2A, CABG over PCI to confer survival advantage with multivessel disease and complex coronary disease. This is the slide for diabetes. New recommendation for CABG, class of recommendation 1, when a LEMA to the LAD can be performed to improve survival. And you can see the 2A and 2B recommendations here for PCI. In the previous guideline, there was only a little asterisk in the table for patients with diabetes, and that was a much lower recommendation. It wasn't even on the table. Another recommendation for DAPT non-adherence, you can see at the bottom of the slide, in the previous recommendations, PCI was a class 3 harm for patients who were not able to comply with DAPT. It is now a 2A recommendation that patients receive CABG or CABG is reasonable in patients who are would not likely not be adherent with DAPT or perhaps could not afford or tolerate DAPT after PCI. And finally, new recommendation for in-stent restenosis for CABG to reduce recurrent events, a 2A recommendation in patients with symptomatic recurrent diffuse in-stent restenosis. CABG is useful over repeat PCI. So from a surgeon standpoint, there are multiple, I think, wins and excellent recommendations for patients who need CABG, whether it be to improve survival, to reduce symptoms, or to reduce cardiovascular events. I hope I've stayed in the time limit, John, and thank you so much for the opportunity to discuss the new guideline.
Terrific, Professor Lawton. Thank you so much. It's very important that these guidelines be presented and discussed from all perspectives, and that has been lacking thus far. SCAS looks to fill that gap, and the next perspective that we'd like to present is represented by what we've called a rebuttal document. Two of the co-authors have joined us today. Dr. Mark Moon, past president of AATS, and Mark Ruel, an STS board member. They have 15 minutes together to present the content of the document, the rationale why AATS and STS did not endorse these ACC-AHA guidelines. I look forward to their remarks, Dr. Moon and Dr. Ruel.
John, thank you very much. Can you see this slide?
Yes.
Perfect. I'll be brief. Mark and I spoke offline, and I'll start with 7 minutes dealing more with the 2B issue, and Mark will talk about the conduit issue. So without further ado, I want to thank my colleagues, and we're all friends here, and we're all close colleagues. And as you said, John, we may agree to disagree. My perspective is slightly different. I do want to thank the tremendous work that every cardiologist and surgeon and layperson has done on the guidelines. Being involved in the current coronary guidelines currently as the STS representative, it is an incredible amount of work. So I'm incredibly thankful to my friends and colleagues for that. Dr. Holland mentioned that the 2B recommendation arose from new data from the last 10 years, i.e. meta-analysis in the ischemia trial. So the main meta-analysis, as you all know, but I do want to put it here, just it's the recent Bangalore meta-analysis. There were other meta-analyses that were essentially similar, but not as updated as that. The 14 trials, almost 15,000 patients. Interestingly, when you look at those trials, they're not CABG trials. The last randomized CABG trial in the last 10 years, as you know, is Stitch Extension Study and MASS2, and they're both in favor of CABG. So there's no data recently invalidating CABG versus medical therapy, 0. These trials here from Bangalore had only 16% of their patients who received CABG. And essentially it found, as we knew from before, from Courage, from Barry 2D, from others, from FAME2, that it's a wash. In chronic coronary disease, PCI doesn't work. And it's no different here, whether you pull the data or not. So ischemia is the other source that led to the 2B. Well, the problem in ischemia is that CABG was extremely rarely used. The type of revascularization was determined by the local heart team. I hear it from very key senior PIs of ischemia that ischemia was not meant to ascertain whether CABG was better or even revascularization was better than optimal medical therapy. It was an initial invasive versus conservative treatment that was being put at stake. So in ischemia, in the invasive group, because we did have an angiogram in those patients, there was multi-vessel disease in 71%, including 3-vessel disease in 40%, and there was about 42% of patients who had diabetes. Yet, only 20% of the invasive group had CABG. In fact, there were more patients who had no revascularization whatsoever in this so-called invasive group, which for some magic turned into a CABG or revascularization group versus a medical therapy group. Again, it's not a medical therapy versus revascularization trial, but unfortunately, it's interpreted in the guideline. It's changing science as if it were. Let's remember there were fewer patients in the invasive group who had CABG than who had nothing, medical therapy alone, if you call that nothing. Even more, I will add, there were more patients in the conservative strategy group, the so-called medical therapy group, even if it's not, who had revascularization than patients who had CABG in the invasive strategy group. This is hardly a trial comparing medical therapy to CABG or even revascularization for that matter. Interestingly, I want to show you here, in ischemia, the effect of a patient being randomized in ischemia having 3-vessel disease, despite adjustment for all other covariates, you see it in the bottom paragraph, is age, sex, region, diabetes, hypertension, current smoking, prior MI, LV function, etc. Despite adjustment for this, patients with 3-vessel disease dropped like flies. Hazard ratio early on, remember only 3 years of follow-up, 2.34, highly significant. Same thing with diabetes, 1.5. Why am I showing this? Because I'm showing you that whatever you believe the ischemia intervention was, I would argue that it's grossly inefficient and therefore not the right intervention because CABG was too rarely used in those multi-vessel disease patients, in these patients with multi-vessel disease and diabetes. So ischemia is not a trial of revasc versus optimal medical therapy. It's even less, much less so, not at all a trial of CABG versus medical therapy, as CABG was rarely utilized. Controls to the rare patients who had CABG in ischemia due to severe coronary artery disease severity cannot by design be produced. So even in 10 years or 15 years, even if we have a follow-up study of ischemia, we don't have the true comparators to those patients who had CABG because they were selected on the basis of an angiogram, which did not happen in the conservative group. So the rare use of CABG, as I was showing you before, failed to curtail the effects of diabetes or coronary artery disease severity on mortality. And that was early on, and despite adjustment for comorbidities. This sounds very much like the effect that PCI was not able to achieve in diabetes or any form of stable ischemic heart disease as seen in COURAGE, Barry-2D, Orbita, FAME2, you name it. So the intervention in ischemia was ineffective and therefore not the right one. And it certainly was not a comparison of CABG versus medical therapy. I will stop with this absurd example. Let's say you're designing this meningococcemia trial that you want to test lumbar puncture plus or minus antibiotics if the puncture is positive, versus conservative initial observation for all kids coming in with neck stiffness, headache, and fever. So you do no lumbar puncture at first versus you start with a lumbar puncture and you give antibiotics if the LP is positive. And they can get the lumbar puncture and antibiotics anytime after the initial allocation. It can be 2 days later, kid fails to improve, gets this. If you were to show no difference between groups, have we concluded that antibiotics have no benefits in meningococcemia? Well, this is so close to the ischemia trial design. And no one in the right mind would say, I'm not going to give meningococcemia to a kid, antibiotics to a kid with meningococcemia, right? This is not what we've demonstrated. This is essentially the inference that's being derived from the ischemia trial. My last slide, the guidelines should not have allocated a class of recommendation 2B for CABG with regards to survival and multivessel CAD, because the old evidence, which is clear, has not been invalidated by anything in the last 10 years. Much to Jennifer's point, it should have given a class recommendation 1, CABG over PCI and diabetes. And it sounds like this was done. So I put this in shaded gray, although it's not immediately obvious, but I thank the guideline writing committee for doing this. And should have given a class of recommendation 1 for CABG over medical therapy in diabetes with regards to MACE, and at least 2A with regards to survival, based on the CABG stratum of Barry 2D and the analysis of Mancini in 2016. Now, I sound like I'm complaining a lot, and this is post-hoc complaining. I do want to say on my last slide that I was the AHA peer reviewer. At peer review, I did put down in writing all of these comments for the writing committee. I yet have to have a specific response about how they were handled, but this is not post-hoc complaining. We saw this coming, and we are very thankful to the writing committee of the guideline, but there are important caveats which I think should be marked down and discussed. Thank you very much. Dr. Moon.
Thanks, Mark. Mine is going to be a bit lackluster compared to yours. I don't have any slides, number one, but number two, I'd like to say that, well, now that you presented those findings, if we downgrade the indications for coronary bypass grafting to treat patients with 3-vessel disease or significant 2-vessel disease with a proximal LAD, it's a moot point what conduit we use, so it becomes irrelevant. But I'm going to talk about the patients that still are getting coronary bypass grafting. Back in 2002, with the late Rick Barner, we wrote a paper on radial artery patency. And when he was a staunch supporter of use of the radial artery, he used it in about 40%, 50% of patients. We found that when it was the radial was used to target a critically stenosed vessel in the LAD or circumflex distribution, it had a similar patency to left internal mammary grafting. But if the lesion was less than 70%, there was less than a 50% 4-year patency rate of the radial artery. And if it was used to a right coronary artery without a significant stenosis, there was less than 25% 4-year patency. The recent guidelines that we're talking about today awarded a class 1 recommendation for use of the radial artery as a conduit for revascularization, but had no qualifiers that said in which patients that would be the case or would not be the case. That being said, yesterday I used a radial artery to a diagonal in a 63-year-old gentleman, but the day prior, I had a patient with a left ventricular ejection fraction of 15% and small distal targets, and I used a Lima to the LAD and saphenous veins to the circumflex and right coronary. So did I perform a derelict operation 2 days ago in this patient with a diminished ejection fraction? The AATS put together the clinical practice guidelines committee that put together not a guidelines, but a expert consensus document and looked at revascularization in patients with a low ejection fraction. And what the recommendation of the experts in that group was that it was reasonable to use saphenous vein targets instead of multi-arterial grafting in patients with poor ejection fraction. Stating the reasons, vasopressors can lead to spasm of the arterial conduits more so than a saphenous vein graft. The adequacy of flow in a fresh artery may not be as robust as a saphenous vein graft, potentially leading to significant coronary hypoperfusion shortly after surgical intervention. Multi-arterial grafting adds complexity and time to the surgical intervention, and the length of the conduit may be a challenge in patients who have dilated ventricles. That being said, also the harvesting of the radial artery is not 100% benign. There are complications. We looked at 786 patients back in about a decade ago, comparing the harmonic versus cold scalpel. But we found in either group, there was an 11% incidence of some sort of hand abnormality, thumb weakness, dorsal hand, palmar hand. Most of those resolved completely. And it was about 1% of patients had a constant and significant source of discomfort late. But that's significant in a, let's say you have a patient who is an obsessive golfer. If he has a thumb injury that lasts the rest of his life, he's going to be affected the rest of his life. Endoscopic harvesting may have less complications than open harvesting. Harvesting obviously is associated with better preservation of endothelial function in some studies, but these things have to be taken into account and discussed with the patient. So the conclusion of that study was this needs to be discussed with the patients. as a possibility. I think the study that the class 1 recommendation was based on was Mario Gaudino, was on the panel here. His multi-study where he looked at a number of studies and combined their data. It was an excellent paper. It was presented at the ATS. The issue with that is it was all from centers, for the most part, that had highly experienced radial artery surgeons. Not every surgeon has experience with the radial artery, and it potentially is something new. And also, those patients were selected for the study, and if only if they were considered suitable for radial use, 75% circumflex lesion or greater than 75% RCA lesion with a good target. So, and also excluded patients with poor left ventricular function or predicted inotropic use postoperatively. So I think the class 1 recommendation may be overstated. That's clearly was not a game changer on the paper that we wrote. That was just an additional finding. And finally, in regards to the methodology of the heart team, most heart teams concept is class 1 indication in almost every document written these days, including non-interventional clinicians, interventionalists, and surgeons. The issue is a panel with an unequal representation that does not use the Delphi method, but simply a majority vote can yield an unequitable assessment by the group that potentially could be biased towards one approach or the other. All of the ATS documents that have been written in the last handful of years have used the Delphi method, setting either a 75 or 85% agreement in order to make recommendations. So I think those are my 2 points that pale in comparison to Mark's points about the revascularization indications, but just something that we added in our assessment. So thank you very much.
So we are now exactly halfway through our 90 minutes for this webinar. And I'm grateful to all the present speakers, very articulate and professional presentations of their viewpoints. And again, we are not seeking to reach consensus. We do not expect everyone will agree, and we respect everyone's right to disagree. Indeed, we can agree to disagree, but we will do that collegially and professionally. Obviously, we've raised several important points, points of contention and disagreement. The very last one that Mark Moon raised was the question of voting, the Delphi method versus a majority vote. And so when it comes to voting, I'm going to now ask Jennifer and Jackie and perhaps John Biddle and some of the other members of the committee can help us understand that the guidelines had 2 non-interventional cardiologists, 9 interventional cardiologists, 8 surgeons, 1 anesthesiologist, 1 NP, and 2 patients, as well as representatives, not quantitated, from ACC, HA, SCAI, AATS, and STS. How many of those, Dr. Lawton and Dr. Thomas-Holland, how many of those folks could vote on each of these items? Were the members who could vote and those who could not vote, or could all of those members vote?
Great question, John. And without getting into the nitty-gritty details of the number of votes and the times that we voted and the times that we revised these things, any writing committee member with a relationship with industry regarding to that topic that we were voting on was unable to vote. If you look at the relationships with industry of the entire guideline, which is publicly available and published, you can see that it's a fairly equal distribution of people in the cardiology field and in the surgical field that had relationships with industry. So it was almost always an equal number of people who could not vote on a certain recommendation. And you know, it has been mentioned, I think, by I'm not sure which Mark mentioned it, but a mere majority, when you think of the Senate and the Congress and the House of Representatives, is not the same as the number of people voting for these recommendations in this process. It was much higher than that. So consensus was achieved in every single recommendation, and every single member of the writing committee signed off on the completed document.
So,
I make
but
a comment.
just to be specific, there were 8 surgeons, and when I tally up the other non-surgeons, they're clearly way more than 8, depending upon how many members of ACC, AHA, SCAI, ATS, and STS were representatives. And I gather now all of those folks had a chance to vote, unless they had to recuse themselves based on a commercial conflict of interest. So from that point of view, it would seem, just again, I wasn't involved at all in these guidelines, although I was a participant in the 2011 predicate guidelines. It would seem clear that the surgeons were outnumbered by non-surgical voters. Is that in fact true?
So, if you look at non-surgical voters,
Yes, ma'am.
they were outnumbered. But if you look at the fact that if you are going to wear a hat, we hopefully hope that when you vote, you don't wear a hat. But if you are going to wear a hat, the hats are the interventional cardiologists and the surgeons. And there were an equal number of interventional cardiologists and surgeons voting on the document when Joe Sabic was part of the document.
Now, you raised Dr. Sabic's name, Jackie. He appears as an author in the JAC document when they indicate how they want the paper to be referenced in the small print, but he's not actually an author in the big print, but authored the rebuttal document that Drs. Moon and Ruel were also co-authors on. Did Dr. Sabic complete involvement in the committee, and did he vote equaling or the eighth surgeon in the group?
So I think we're permitted to say that Dr. Sabic was able to participate in all of the parts of the voting process, the signing off of the document to peer review, until the point with which he withdrew. I don't think we're allowed to so to say at which point he withdrew, but until the point he withdrew, he was part of the writing committee.
Okay. The most contentious point that has been raised by numerous surgeons and organizations has been the downgrading of coronary bypass surgery and stable ischemic heart disease, 3-vessel disease, from a class 1 to a 2B. And the criticism fundamentally has been that the ischemia trial data and perhaps a revision of interpretation of prior data should not have validated that kind of a downgrade. I wonder, is Dr. Taggart on the call? I'd like to get input from our ISCAS board member.
Yes, he is in attendance, Dr. Busquets.
David, can you provide some perspective on the evidence base? Dr. Ruel made a comment, several comments about the role of ischemia in this downgrade. He's arguing that that trial does not really constitute evidence that would overturn the prior evidence for CABG and stable ischemic heart disease to make a downgrade from a class 1 to a 2B. You've been outspoken in that regard. Can you summarize your thoughts on that collegially in a few moments? You're muted.
Dr. Taggart, I've given you the ability to speak on your system.
We've lost him.
Actually, Dr. Taggart, if you choose to use the chat box, you may do that as well.
And
while we're waiting for Dr. Taggart, perhaps
Yeah.
I could make a few comments. While the ischemia trial did play a role in the decision-making, it wasn't the only trial that had the committee make this downgrade in the recommendation. There have been other trials that have suggested the same thing. And I don't think anybody would say that somebody has poor ejection fraction, poor heart function, has 3-vessel disease. They're not a very good candidate for bypass surgery. I think the contentious issue comes in with people that are relatively asymptomatic and had normal left ventricular function. There have been, I don't think, any trial to demonstrate that they do have improved survival. You can go back to the CAS study. The people that had 3 vessel disease and normal left ventricular function, there really wasn't a survival benefit. There was only a survival benefit if they have a reduction in their ejection fraction. Again, while the ischemia trial did have a major role, and some of us would maybe contend that it had too much of a role for some of the reasons that Dr. Rell brought up, that's not the only evidence that the committee considered.
Frank, even if you look at the older trials, there were 3 main pivotal trials, and CAS was negative. The VA cooperative in the non-left main subset was negative. There was really the only European coronary surgery study that showed a benefit in triple vessel disease with normal LV function, and the meta-analysis of those trials.
And just to add, in the European study, it was primarily for left main disease. And so the benefit of VA cooperative was for patients with low EF, for the European study, for patients with left main. Those were given class 1 indications in the guidelines. Even if you look at the USEF meta-analysis, which was used to justify the previous guidelines, again, the overall meta-analysis, if you exclude left main, was not significant. So I think it was based on the fact that we're giving a class 1 indication for left main and low EF, and that the other studies, even historically, didn't strongly show a benefit. Ischemia was just one thing that added to that. And additionally, the 500 patients in ischemia outweighed the total number of patients enrolled in the individual studies for CAS, the VA, and the European study. So it wasn't necessarily a tiny group of patients.
Perhaps, Dr. Don, I can respond respectfully to that. The effect modification with regards to left main LV dysfunction in the USEF meta-analysis, which arises from Canada, but it's an international effort. It's a patient-level data meta-analysis, as you know. The effect modification only appeared after 5 years. The interaction term, in the first 5 years, it was everybody was benefiting from it on the IPDMA. So I think we have to be careful with, although these did set out the classic indications, LV dysfunction, 3 vessel, left main, etc. Before 5 years, that interaction term was not statistically significant. Everyone was benefiting at the individual patient data level. So I think we have to be very, very careful that it's not additional precision given by very long follow-up that invalidates what we're seeing. And as you know, ischemia is 3.2 years. So I would just provide that caveat.
Mark, I'd like to point out that the USEF meta-analysis was published almost 30 years ago. And the ischemia trial is contemporary data. We could not ignore it. And
no, but there's no data that pertains to CABG versus medical therapy. Where's that data? Yeah, where's the control of the patient who had an angiogram, say with a syntax score of 35? As you know, CT scanning, and not everyone had a CT scan. About 26% of patients did not even have a CT scan. Where's the control to that patient? How can we identify that control?
It's not a CABG versus medical therapy study, but let's look at the patients who were randomized to the strategy of a conservative approach. You're right, 20% of them got revascularization. But one thing that hasn't been mentioned is that their 4-year survival was 94%, which is much higher than any survival rate than any of the earlier studies, which points out that maybe optimal medical therapy is having an effect. We could not ignore the data. A class 2B recommendation does not mean that surgery should not be done for patients.
No, I know, but it doesn't invalidate.
And it gives us a lot more leeway.
Yeah. The problem is that there's data that's showing it's exactly this data that's being extrapolated to show that antibiotics have no role in meningococcemia. It's exactly the same example. It's so much closer to that than any trial of surgery versus medical therapy that you could imagine, right?
Well, without further interruption, I think we should point out that the 2B recommendation is not carved in stone. If there is a divergence of survival curves seen in ischemia in the future, these recommendations will be modified. We will issue an update.
Yeah.
And
there cannot be
a word, and it doesn't mean you cannot do surgery.
Yeah, there cannot be a divergence because the controls to the CABG patients are not available by design. You don't have an angiogram to determine who are these syntax score 36 patients, or who are these high burden of coronary artery disease patients, who are the controls in the conservative group.
You actually do.
Those controls are not available, right?
You have a coronary CT angiogram.
Yeah, but you don't determine syntax score of that. And 26% of patients didn't have it, didn't have a CT. So not everyone, that's a common misconception that everyone in ischemia had a CT. There's a high percentage of patients who didn't have it, about a quarter.
Yeah,
There were patients in ischemia who didn't even have coronary disease, but there was a sub-analysis looking at the patients who had triple vessel disease, and there was not a mortality signal in that. So if
Yeah,
there
but they
was,
had a hazard ratio for death at 3 years of 2.5. Is that a good intervention, or are we back to the 1970s?
but
Before
compared to the
coronary
two
surgery
groups,
was
the
safe and widely
mortality
applied,
was equal.
I think it's more the latter. I think we're back to 19, despite adjustment for other risk factors, these patients are dropping like flies at 3 years, at less than 3 years. Is this progress? I don't think so.
Let me ask.
It's a
Dr.
6% mortality at 3 years. I don't know why you're saying they're dropping like flies. That's the same as the mortality rate in CAS for multi-vessel disease, for single vessel disease.
Yeah, but look, yeah, if you look at the Reynolds and the Newman paper, you'll see I showed that hazard ratio. Hazard ratio for 3 vessel disease, the few patients who had very severe coronary disease are dropping like flies in ischemia. Of course, they're washed in the
relative
overall
risk
population.
is important, but absolute mortality rates are also critically important to look at.
One of the items that was focused on in the STS-ATS document was that an objection to the landing of both CABG and PCI at the 2B category, that they shared the same level. So there was, I think, a fundamental concern that the CABG recommendation had fallen from a class 1 to a class 2B, which is a big drop, and the PCI had landed at the same spot, where PCI is described as benefit uncertain and CABG may be reasonable, but they get the same in the end. They get the same class of recommendation. What are your thoughts on that, Dr. Don, and then Dr. Moon?
I'm sorry, could you repeat the question? I was having.
Sorry,
One of
one of the objections was in the STS-ATS so-called rebuttal document. There was concern not just that CABG had fallen from a class 1 to a class 2B recommendation in stable ischemic heart disease, but that PCI had landed at the same spot at 2B. Although the language around the PCI was that benefit was uncertain, and the language around CABG was maybe reasonable, but yet they, in the final analysis, they both have a 2B.
I think that's a valid point, actually. That's what there is some back and forth about the language there. And I think that the language says may be reasonable for CABG and is uncertain for PCI, which is a strong distinction. So I don't think it fell in the same area. And the other thing is when something's a 2B, it still means that we think that the benefit outweighs the risk. So I don't think that he landed in the same spot.
Yeah, I heard that a lot. I would very politely object to that. I think, like an abstract, 99% of people read the table. I'm currently involved, as I said before, in the coronary guidelines. I can't reveal anything about it, but we are very cognizant, as you are, I know, that the vast majority, overwhelming majority of people just look at the table. They don't even read the synopsis and they don't read the fine print. So I think we have to be cognizant that 2B is 2B. And even though the language between CABG and PCI is different, and I thank the author for the thoughtfulness in making those two languages different, the bottom line is still 2B is 2B, right? Especially for an internist or family doctor or someone you may refer or not refer a 3-vessel disease patient or a diabetic patient to CABG or not.
I come back to the Delphi method, and I think this is a consequence of the majority rules type approach to evaluating. And Dr. Lawton did mention the majority rules in the Senate and the House of Representatives, but it does not when you're impeaching the president. It has to be a 2/3 majority. And so that is my thoughts in regards to changing the guidelines that have been in place for 20 years. Has to be more than just a simple majority.
Now,
Mark,
one of
if
the
it
comments
would
that,
help you feel better, I can tell you that the majority was always 2/3 or more.
Well, that's not in the document, and that's not how the situation was set up. So we don't know that. Now we know that, but we don't know that.
There's a tremendous amount of discussion and thought that went into all the guidelines, not just the revascularization for 3-vessel disease. And it wasn't just the surgeons against the non-surgeons. I mean, we talked about this for weeks. We had multiple extra sessions, multiple extra votes, and this is the consensus that we came up with. And everybody did sign off of it. Yes, there were some difference of opinion at the end, but there were tremendous amount of thought that went into all of these guidelines.
Frank, one of the concerns, of course, in the bigger picture is that ischemia has been used and overvalued in its overinterpreted a trial that wasn't designed to and did not compare CABG versus PCI or even CABG versus medical therapy. That is not the structure and design of ischemia, but that it was overvalued because it is contemporary. And some of the other data upon which the 2011 guidelines and the class 1 recommendation for CABG, some of those other data are older. I'm getting older. I don't think I'm less valuable, but I understand the attraction of contemporary data. The most contemporary data is FAME-3, which, despite a surprisingly short follow-up, has a striking advantage for CABG over PCI. Dr. Biddle, Dr. Don, was FAME-3 considered in these guidelines?
FAME-3 was reported and published after the guidelines had been voted on, and did not show an overall mortality advantage for bypass surgery. I tend to avoid using terms like trends, but it did it did show that CABG or PCI was not non-inferior to CABG. So
Yeah.
that's a part of the process for moving forward. We will look at FAME-3. There will be longer follow-up, undoubtedly, from FAME-3. There'll be longer follow-up from ischemia, for better or for worse. And these guidelines are not carved in stone. We will issue an update.
But that FAME-3, again, does not address the question you guys are all contentious about.
Yeah,
It doesn't address the question of CABG versus medical therapy.
that's right.
Perhaps maybe in future guidelines, we'll have a 2A to reduce the risk of cardiovascular events with CABG over PCI for all comers based on FAME-3. Who knows? But it doesn't address the question you're talking about.
Yeah, I agree with both points that you made. FAME-3 came after. FAME-3 has, and I agree not to use trend, very surprisingly showed an advantage for CABG early on at 1 year. And the hazard ratio for death, very few deaths, but amazing numbers, right? 1% 1 year death after CABG, and about 50% higher with PCI, but even too soon to call it a trend, but the hazard ratio is 1.4, 1.5, right? Probably in future years, there'll be something coming out of that. But I completely agree, and we face the same, without giving specifics, it's always, when you see CABG being superior to PCI, then you have two choices. Do you extend that to CABG being superior to medical therapy? That would be probably logical. But then if you don't do that, then you have to accept that there's a remote possibility that PCI might be worse than medical therapy. And maybe in some cases in stable ischemic heart disease, that's the case. That's very difficult. That's the difficulty with interpreting freedom, right? Because you have very scant data in diabetes of CABG directly versus medical therapy. It's basically a stratum, the CABG stratum of Berry 2D. And then the Mancini meta-analysis, which used individual patient data and kind of mishmashed it together. But we have very strong data against PCI from Freedom.
One issue that really hasn't been brought up yet is medical therapy has gotten so much better since the early trials. In the CAST study, there was aspirin and beta blockers, and we didn't know what to do with beta blockers. I remember I was in medical school then, and they were debating should propranolol be the first line in the treatment of hypertension versus hydrochlorothiazide. We never gave Lasix because people thought it would drive people out like a potato chip. Now we have statins, we have ACE inhibitors, we have more superior antiplatelet agents. So the landscape is changing as it is with PCI and CABG.
And CABG, yeah. Especially CABG. I mean, FAME-3, 0.9% mortality at 1 year, 1.1% stroke at 1 year. This is half of what was seen in the old trial, Syntax and Freedom, where patients were having strokes. I mean, the safety of CABG now is unbelievably improved. I like to argue, I make this point to Mario when we chat on Saturdays. I think the technological advances of CABG have probably surpassed that of PCI and medical therapy altogether. but we fail to measure it, we fail to recognize it.
So what do we do about the previous studies that the document, y'all's rebuttal said that we underemphasized? 1985, 1994, 1996, 2001. When do those time out?
They time out when you redo a trial, or if you think that the evidence, there's something to, there are things that are set in stone in medicine that we don't redo a trial about. And again, back to that stupid example, but meningococcidia and antibiotics, are you going to do a trial tomorrow, say we're going to withhold antibiotics? I think it's pretty well accepted. So I think these trials were definitive, and rightly or wrongly, we don't have anything that invalidates them. It would be nice to have something better, but there's nothing better.
So that's how we used ischemia. It wasn't to invalidate the previous documents, but it brings up a change in perspective that medical therapy is better.
To me, it brings zero information on that question. The CABG versus optimal medical therapy, ischemia brings zero information.
I think, Mark, let Brittany speak, because you have made your point very clear, and I think we all understand that. I think Brittany is raising a point, which I think is a fair point, and so Brittany, maybe say what you have to say.
Well, we didn't use it to define the survival data as the rebuttal has suggested, but we think that it represents a change in our understanding of medical therapy. The data demonstrates that therapy is better. It's different. It encourages us to reevaluate our understanding of the treatment of coronary disease with PCI, medical therapy, and surgery. So as we move forward, what do the trials need to look like? Should we continue to use these composites? FAME3, my understanding is the primary endpoint was a MACE, was a composite. And yet we want to use it to completely validate the role of survival, of CABG for survival. But that's still, looking at the data in its purest form, it's still a composite. How will we use that?
Well, Brittany, we have other trials that are still relatively contemporaneous or contemporary. We have Freedom, we have Syntax, we have Excel. In Freedom and Excel, there's a mortality benefit for coronary surgery over PCI. And while these are not yesterday trials, they're big and well done trials. Freedom focusing on diabetic patients, of course, and Excel on left main patients. So, I don't think that ischemia, which was not designed to compare CABG and PCI, should invalidate the interpretation of those two studies.
John,
Go ahead.
speak for a moment? Here the comparison is not CABG versus PCI. Here the comparison is CABG versus medical therapy. This is the key question that I think is getting confused. The comparison is not between surgery and PCI. For that, we have already elaborated, and I think overall surgery as the guidelines are favorable to surgery compared to PCI. The question the AATS and STS have criticized is not CABG versus PCI, but it's CABG versus medical therapy. So you cannot use CABG versus PCI data to infer the treatment effect of CABG versus medical therapy, even though I can see the logic. That is not what
I would respectfully argue that unless PCI is harmful to patients with multivessel disease and stable ischemic heart disease, then CABG can't have a 2B recommendation. If CABG is better than PCI and CABG is 2B, then is PCI class 3? I mean, there is a commutative principle. If we're going to use inferential analysis of data sets, you have to wonder, how can we have a 2B for CABG if CABG is better than PCI and PCI doesn't harm patients?
I know of at least a dozen randomized trials of meta-analyses comparing PCI with medical therapy for patients with multivessel disease, showing no difference in overall mortality. And it goes back to AVERT and TIME and the MASS2 trial, COURAGE trial a little more recently, and then up to the current era with a whole series of meta-analyses. So I don't think anybody can make the claim that PCI is more dangerous than medical therapy and results in a higher mortality rate.
Well, precisely, John.
I was being rhetorical, and I agree with what Dr. Biddle has said. It's true that there have been many trials that have not demonstrated a benefit of PCI over medical therapy, but I don't recall one that's demonstrated that PCI was worse than medical therapy or harmful. But if cabbage is better than PCI and cabbage has a 2B, I'm stuck in trying to figure out where PCI fits in as we infer between different data sets.
John, a couple of points. One is the comparative trials of different modalities. They were a mixture of stable ischemic heart disease or chronic coronary syndrome plus ACS. And I think we all will accept that PCI has a survival advantage in ACS. As far as the logic, in terms of cabbage improving survival, if you go back to Yusuf, the 3 important subgroups that were shown at 5 years, survival advantage. Biggest is in left main, but very small population. Next was in LV dysfunction, although that was in people with an LVF less than 50%. And the third, which was more moderate but still high, was triple vessel disease. In the meantime, there's been no single trial comparing medical therapy in cabbage with left main disease. There's been STITCH and STITCHES, which has shown a survival advantage in cabbage compared to medical therapy. But as other people have said, there's not been a single trial that shows survival advantage with cabbage compared to medical therapy in the era. And that's ischemia, Berry 2G, MAST2. Now, and that's in people with normal EF. So I think it's all fairly consistent. I agree that longer term follow-up of ischemia will be helpful, it's essential. And we really haven't seen the comparative outcomes of cabbage versus PCI. But so far, this is what we have. And as many people have said, it's a living document, and it's not written in stone, it's written in paper. And we can see a revision in a few years, hopefully, with further follow-up.
So Steve, I don't agree. I think further follow-up of ischemia will not be helpful to answer that question. I think by design, it will not address it whatsoever. You'll never get too counterfactual to the cabbage patients. And the last question I would have is, if you go on Fifth Avenue and you find you're in New York and you find people who walk a little slowly or a bit obese, and so I'm going to randomize you to medical therapy versus cabbage, and you find no survival difference at 3.2 years, does that invalidate cabbage? I'm just going to leave you with that.
Mark, I'm going to leave you with this. Take a look at the original pivotal trials. I'm going to stress again, there were 3 main big trials. They were about 750 patients, and 2 of the 3 did not show a benefit in the subgroup of patients with triple vessel disease who did not have left main disease and had normal LV function. Only 1 did. When you look at the meta-analysis by Navarrese, which included those 3 pivotal trials, and specifically did a subgroup where you looked at only cabbage trials and then all trials, there was no benefit to overall mortality in revascularization with either cabbage or PCI, but then in the subgroup of patients, there was a similar lack of no benefit with cabbage in the cabbage trials.
Jackie, did that include diabetic patients? Freedom?
It was the Freedom again is about PCI versus cabbage. This is a subgroup, a meta-analysis of all trials of patients with multivessel disease, looking at revascularization versus medical therapy. And then there's a breakdown. There's a reduction in cardiovascular mortality and reduction in MIs. And that's why we have a recommendation for reducing cardiovascular events with revascularization. But there's no benefit in terms of mortality. And I think that's what our problem is as guideline writers. And this is ESC, this is current guidelines. We focus too much on mortality. In the literal interpretation of the word, there is only 1 trial, and that's the VA, the European coronary surgery, that showed a benefit to reducing mortality. There's been no
others. It seems very unlikely that we're going to have a cabbage versus medical therapy trial done anytime soon.
Then when the 3 trials were put together, that mortality benefit was there. We've also had decades of phase 4 surveillance. I mean, you have in your practice patients who've had cabbage many years ago, decades ago, who are still alive. I think, and we have evidence in LV dysfunction. We have indirect evidence from MI. We have a 30% increased odds of survival. I realize these are left mains in Excel and in diabetic patients. We have so many indicators from all sides, yet we use a meta-analysis where 16% of patients receive cabbage, and we use a trial that did not compare surgery to medical therapy to invalidate previous class 1 acceptance of indications for multivessel disease.
So I think we've reached the point where we're going to have to agree to disagree, and to do so collegially. And I'm grateful to everyone for expressing their opinions on this point. I'd like to steer the conversation to some of the other points that have been raised and that are very interesting and important. One of the contentious points in the STS-ATS document is purely surgical. And I would like for the cardiologist to listen to the next little exchange of ideas and then give us your impression of watching surgeons fight over which arterial conduit to use. I'd like to invite Dr. Gaudino to present the case for a class 1 recommendation for radial artery. And I'd like to ask Dr. Moon to rebut. And then I'd love to hear the cardiologist's view of this discussion. Let's try to devote another maybe 10 minutes to that conversation. Dr. Gaudino, can you tell us everything there is to know about the radial artery as a conduit in 5 minutes?
Sure, Mark, I hope you can see my screen. I will be even shorter than 5 minutes, I promise. So this is the question that has been criticized. I think, well, the radial artery class 1 indication, but I think that this is also related to the class 2A indication to the bilateral internal thoracic artery graft. So I will briefly review the reason why we thought the class 1 recommendation, the radial artery, was appropriate. So there is a large observational evidence that support longer survival for patients to receive the radial artery rather than a saphenous vein as a second graft. This is a meta-analysis of 14 study, 20,000 patients. There was an added ratio around 0.7 at 7-year follow-up in favor of the radial artery. We know observational study are hypothesis generating only. There is a clear treatment allocation bias. So I think we should rely more on the randomized data. This is a network meta-analysis of all the trial that look, randomized trial that look at patency rate of the different arterial and the venous conduits using bypass surgery. 14 trial, more than 3,600 graft. And you see that there is evidence for the radial artery of a better patency rate compared to the traditionally harvested saphenous vein with a relatively large treatment effect. Interesting, the only other conduit for which we have proof of a better patency rate is the no-touch saphenous vein. For the right internal thoracic artery, the number of study was small, but treatment effect did not reach significance, and you can see the details here. So if we focus on the radial artery, we have observational evidence of a potential benefit. We have randomized evidence of a better patency rate. So we have a mechanistic explanation why the radial artery should be better than the saphenous vein. We do not have a randomized trial, a single large randomized trial that are compared clinical outcome for patients who receive the radial artery saphenous or versus the saphenous vein, but we have the patient level meta-analysis that Mark Moon was referring to. By the way, I would say that the center involved were not necessarily radial artery center, because the Melbourne group that is part of this meta-analysis has been known for decades to use the right internal thoracic artery. In any case, in this patient level meta-analysis of 6 randomized trial, there was a benefit in terms of a composite of death and cardiac event at 5-year follow-up, and also again evidence of better patency rate for the radial artery, providing a mechanistic explanation for the clinical benefit seen. And when the follow-up was extended to 10 years, not only the benefit for the radial artery was seen for the composite outcome that included death, MI, and repeat revascularization, but also for a more clinically meaningful composite outcome that included only death and myocardial infarction, so only clinically relevant event. We also saw a survival advantage, but this was a post-hoc analysis, was based on a small number of patients, so this must be seen only at hypothesis generating. So to recap, For the radial artery, there is observational evidence that suggests the patient who receive the radial artery lives longer than patients who do not receive the radial artery and receive a venous vein. There is good observational randomized evidence that the patency rate of the conduit is better. There is moderate randomized evidence that suggests an improvement in clinical outcome. It is not perfect, but it's at least is randomized. But most importantly, you know, when you give a recommendation, it all matters to a risk-benefit ratio. And we felt that the risk of using the radial artery is relatively minimal. The hand complication that Dr. Moon was referring, as he has a knowledge, are transient and generally are gone by 6 months, a year from surgery, and using adequate preoperative evaluation of the ulnar circulation, there is almost no risk of severe complication. Things are different for the bilateral internal thoracic artery, where the evidence, the observational evidence is strong, but the randomized evidence is lacking. And actually, I would say the randomized evidence is for lack of a survival benefit after the ART trial. There is no randomized evidence for better patency, and the risk-benefit ratio is also different because the potential complication of harvesting the bilateral internal thoracic artery are much more severe than the potential complication of using the radial artery. And so I think this is consistent with our recommendation, and I think I can stop share my slide. And I think that summarizes our thought process.
So there's obviously a large body of evidence supporting double mammary grafting as providing better survival than single mammary grafting. Much of that is non-randomized and observational, but it does have a biological rationale that the internal mammary artery is biologically and anatomically different than other arteries in the body, having a much narrower or thinner layer of muscular tissue and being less prone to spasm than arterial or peripheral vessels are in the arm or leg. So there is some advantage. That has been a long-standing sort of dogma in cardiac surgery of double mammaries, but in truth, the trials to demonstrate that are not as thorough as the data that you've seen from Dr. Gaudina about radial arteries. So, Dr. Moon, what's wrong with a class 1 recommendation, perhaps with some language about when to use a radial artery and when not to use a radial artery? I've often said that a good vein beats a bad artery any day. And I think that's still true, although I use almost exclusively arteries in almost every operation I do. But there are times when a good vein beats a bad artery. Can we craft a class 1 recommendation for radial arteries that STS and AATS would be happy with?
I think we probably could craft that. The issue with the class 1 recommendation is essentially if you don't do it, you're doing the wrong thing. And that I think is the problem. Every surgeon should not feel compelled they need to use a radial artery in every single patient. All the patients in Mario's study, which was an outstanding study, were selected only if they were considered suitable for a radial artery. So, and then they were randomized to radial versus saphenous vein. So I think we need to have qualifiers for what is considered a suitable artery for use of the radial artery. And the same is true with the beta. For the right internal mammary, there may be vessels that are not suitable for that as well, or patients that are not suitable for that as well. So I think we need to be careful when we make class 1 recommendations without qualifiers.
So I think, John, sorry, I think here we can agree because actually in the guideline, we have a very, very detailed best practice table that highlight what are the indication and what are the situation where the use of the radial artery is more likely to provide benefit. And I think basically we are discussing the same issue. And I agree with Dr. Moon that the radial artery is not a conduit you should use in every single patient. And there are situations where honestly, you should not use the radial artery. So I think it's a language issue rather than a concept issue, and the qualifier are definitely a good idea. Again, we have that table that may have been overlooked in the recommendation. We speak about severity of the stenosis in the main the recommendation. We say only for target vessel with severe stenosis, but we relied a lot on that table, Dr. Moon. Another option is to put the qualifier in the recommendation itself. I think both options are perfectly fine. So I think in this case, we are more on the agree than on the disagree side.
Yeah, and I think making a level 1 indication is a way to move the needle so that more people will use it, although we don't want them to overuse it. For example, when people made a recommendation that the ascending aorta 5 centimeters should be replaced, that had people who did not do aortic surgery doing aortas that were 5 centimeters with suboptimal results in many cases. So we have to be careful.
Well, I think we can advocate for coronary surgery as a specialty and these sorts of all arterial grafting to be done by surgeons who are focused on coronary surgery within a faculty. Jackie Creighton, John Biddle, what do cardiologists think as you watch surgeons beat each other up over which arterial graft to use?
Yeah, so I think it's very interesting, and I will be honest, while I completely respect the data on radial artery, in the end, the most important thing for us is that the patients get multiple arterial grafting. And I do recognize this importance of the radial artery grafting, as Mario pointed out. I think it's really important, but I wouldn't scream over the fact that somebody got a bilateral IMAs instead of a radial artery. I'd be very happy as long as they got a lot of arterial grafting.
Terrific. Now I'd like to segue to a last comment, because this is something that, or last discussion point, because this hasn't been brought up thus far. In the present document, the ACC SCAI guidelines, the performance of a syntax score at the time of diagnostic coronary angiogram has been downgraded from a class 1 to a class 2B recommendation. And I think that largely flew under the radar for many. It wasn't mentioned in the STS AATS document in response to the guidelines. When I read it, I was concerned that the syntax score is the fundamental quantitative or data-driven metric for appropriateness criteria, and that if we didn't do that on a regular basis, or at least advocate that it should be done on a regular basis, that we would have a difficult time establishing a quantitative or evidence-based way of assessing appropriateness criteria for various kinds of revascularization or for revascularization at all. And as you know, a leader within the International Society for Coronary Artery Surgery, and we're seeing some of our other board members brought up to the panel level to address this question, I know that globally there is a big disparity in CABG to PCI ratios, sometimes within one city or within one country, but even between countries, without an obvious biologic rationale. I mean, the PCI to CABG ratio is 25 in Japan and 6 in Mexico. What will the removal of the syntax score lead to more inappropriate procedures? And how will we better quantitate appropriateness of intervention in the absence of a syntax score? Jackie, would you like to, or John Biddle, would you like to address that? Now I'd like to have some input from some of our international members, including Dr. Taggart from England, Dr. Trehan from India, and perhaps Walter Gomes from South America.
I'll speak up. I think the syntax score has been an important advance for investigational studies. In practice, it is onerous and difficult to calculate. That's not an excuse, but the 10 or 15 minutes that is required to calculate it might be better used to counsel patients about smoking cessation or blood pressure management. Not every study has shown that outcomes based on revascularization mode are predictable by the syntax score. Some studies have, some haven't. So we did not want to make it an obligatory part of the angiographic evaluation of a patient. A 2B recommendation, again, does not mean it should not be done. It may be considered in every patient.
And here again was where the guidelines are a little different from AUC, because what the guidelines are trying to give you is what is the evidence behind this. And the syntax score that was used to distinguish CABG versus PCI is based on these sub-analyses. So the evidence was not overwhelmingly strong for it, and that's what the guidelines are saying. It doesn't mean that it can't be used, and it perhaps should be used, but we didn't want to be overly prescriptive, because if you have a syntax score of 24 versus 21, which is often in the eyes of the beholder, does this mean you should absolutely change your practice? And this is what we wanted to avoid with the guidelines.
Well, we know that the complexity of coronary disease impacts the benefit of PCI, while the complexity of other comorbidities impacts the risk for cardiac surgery. If we're not going to quantitate the complexity of coronary disease in deciding alternative revascularization with a syntax score, how are we going to do it? And how will this lead to more appropriateness, or will it lead to the opposite?
And I think this is where we deferred some of these questions where there wasn't overwhelming evidence to the heart team. And this is where we give power to the individual providers and the heart team and the individual centers, looking at their own expertise, their own risk and benefits in their individual centers to make some of those decisions. We didn't invalidate the syntax score, really just saying that it should not be the sole determining factor in making these decisions.
So I'm going to push back a little bit and say, I know it's onerous, but I'm asking, why can't we have AI do it? Why can't we develop technology that will have it calculated automatically? And even if we couldn't do that, why can't we teach a whole generation of clinicians to evaluate it quickly and effectively? We managed to teach a whole generation of clinicians how to do TAVR in 1,000 centers in America alone. It took a lot of investment, but it got done with remarkable skill and safety. Surely we can calculate a syntax score with a lesser investment and guide the discussion of the heart team. But I want to hear from Dr. Trehan from India. Can you unmute yourself and perhaps Dr. Gomes from Brazil? What are your thoughts about appropriateness and the use of the syntax score? Is it important that the syntax score is a 2B now, or versus a class 1, or does it just not matter?
Either Dr. Gomes or Dr. Trehan, you can unmute yourselves. You are now both panelists.
Yeah, thank you for the opportunity, but I want to go back with the contest about the radial artery and I talk with Mario Gaudino. We have several concerns about the using radial artery, mainly in no critical coronary blocks. Also, when grafting right coronary arteries with radial arteries, the long-term patency is inferior. And also the reliance of the radial artery on a medication, anti-spastic medication for long-term patency. It's also concerning because most of the patients are not adhering to this long-term medication and then compromise the long-term outcome. I want to hear from Mario Gaudino about this reservation about the radial artery. Thank you very much.
Thank you, Walter. I will be quick because I don't think that was the topic, but you are right, meaning that, and I think this is also what Mark Moon is saying, the radial artery is not, there are situations where you probably should use a vein rather than a radial artery, but this is not the majority of patients. This is a minority of patients. And that's why we have that table that highlight the best practice, meaning the situation where a benefit for the radial artery is more likely to be true. When you write the guideline, you are writing for the average patient. You're not thinking specifically to the patient who has a moderate right coronary artery stenosis or the patient that cannot tolerate calcium channel blocker therapy. You are thinking for the majority of the patient. And so in the majority of the patient, the use of the radial artery is more likely than not to provide a long-term clinical benefit in exchange of minimal addition or increase of the operative risk, if any. And so this is the basis, the rationale for the class 1 recommendation. Now, guidelines are for the average patient and the average surgeon. They don't take the place of clinical judgment. If you have a patient with a moderate right coronary artery stenosis, well, you should not use the radial artery. That is in our guideline, in our best practice table, but it's also based on the fact that clinical judgment trump guideline. Overall, the majority of the evidence suggests that there is a benefit by using the radial artery, that the risk is low, and this is the rationale for the recommendation. I hope that answers your question.
Still see Dr. Trahan muted. Naresh, are you able to unmute yourself and give us a comment about PCI cabbage ratios in different parts of the world, and your thoughts about whether syntax is important to optimize appropriateness?
Dr. Trahan, if he can either unmute himself or he can use the chat feature if he is unable to do that.
So, John, while we wait to Dan, let me make one point straight. The syntax score calculation has never been a class 1 in any guideline. It was a class 2A indication for left main and 2B for multivessel disease, as Jennifer wrote in the chat. So we have not downgraded even syntax from 1 to 2B. That was another recommendation. And we haven't said that the complexity of the coronary disease is not important. We have just said that the syntax score per se has not been proven to be a significant treatment effect modifier. And so you should not rely only on the syntax score for your decision, but we haven't said that the evaluation of the complexity of coronary disease is not important.
So Mario, the syntax trial clearly showed that the syntax score was associated with better benefit. The more complex the disease, syntax scores over 32 were clearly a category in which cabbage outperformed PCI, while syntax score less than 22, PCI was non-inferior. I mean, so
no, John, yes, but this is not a validation of the syntax score. Actually, the syntax authors clearly acknowledged that in their publication. That was a post hoc analysis. And there has never been a formal validation of the syntax score. To make things clear, patients were not randomized in syntax based on the syntax score. So that was a post hoc observational analysis of the syntax trial. Again, the syntax authors acknowledge in the main publication that that was hypothesis generating and further validation of the syntax score were needed. There has never been a formal validation of the syntax score. And when you pull all the trial, we have done it on a meta-analysis on GTCVS. When you pull all the CABG PCI trial and you look at the analysis based on the syntax score, which is again observational in each trial, but when you do this exercise, there is no correlation between syntax score and the result of PCI versus CABG trials. So that was the rationale for giving a less strong indication, not to the evaluation of the complexity of the coronary disease, which is still important, but to the syntax score per se. And to add to that, we know there is a lot of variability in Excel. 20% of the syntax score that were calculated at the site were not confirmed then when the syntax score was recalculated centrally. So there is also a problem of reproducibility with the syntax score.
So the reproducibility problem certainly exists, but we understand that the syntax score has been a very important criteria for entry into the Excel trial, for instance, for understanding of CABG versus PCI in different strata of the syntax trial. And it had become a pretty common conversation piece at our heart team meetings. What are we going to replace it with? How are we going to have those conversations about complexity of coronary disease? How will we grade and evaluate and monitor appropriateness of intervention? A nihilistic approach, we're never going to do a randomized trial that truly statistically validates the syntax score. That doesn't mean we should throw it out and have nothing as a guideline.
So, John, if I may interject, I don't think we have nothing. I think the next dimension is going to be longevity and functioning at baseline. And another post-hoc analysis of syntax, like what led, as Mario said, to the syntax score, is remember they had quality of life and physical and mental functioning assessments at baseline and at 1 year. Now, there's a very interesting analysis that will come out in circulation in the next few weeks, analyzing the interaction or effect modification of patients according to baseline functioning. It's very interesting to see. Like I tell my colleagues, don't do CABG and someone's not going to live 5 years, right? And I think it makes a lot of sense. I think longevity potential, non-frailty, functioning at baseline is going to be a very, very important effect modifier of the decision as to whether someone should get CABG versus PCI versus medical therapy alone. I think when you have high functioning and good longevity, that should really steer the needle towards CABG. But that's still a developing field, but be on the lookout for a very important publication about to come out on this.
Well, many of us have felt that way for a long time. I've said, I think we do way too much PCI in young people and way too much CABG in old people. The survival curves don't begin to diverge until 3 years. If you've got 2 years to live, why are we having a conversation about CABG? Exactly. But if you're 50 and diabetic, why are you having a conversation about PCI?
That's right.
And but I think that those conversations need to be informed to the extent we can with some data, some quantitative data about PCI complexity, because there are type A lesions and there are patients who benefit from PCI. It's quick and easy and it gets the job done. That isolated tight right lesion is a beautiful treatment with PCI. My own father had that. But a complex LAD lesion is better off with a lima. My favorite cardiologist's father had that. And we have these conversations between us.
John, if you did a complex LAD lesion and you calculated the syntax score and there was no other disease, it would be a low syntax score. So the bottom line is we as cardiologists look at the complexity of disease. We highlight in our document the aspects of disease that makes it complex: tortuosity, CTO, calcified lesions, bifurcation lesions, et cetera. And we know in our heart what's complex or not. And as you said, you can have a really complex, totally occluded LAD, and they're going to do better with a lima to the LAD. You are right. But if we calculated the syntax score, it would be low. So that's why we took the syntax score. That's not exactly why, but one of the reasons why. It's about cardiologists looking and knowing complexity the same way you can walk into a room and know somebody's STS score is off the roof without actually calculating it.
Will we have appropriateness criteria in the future? And will they be quantitative? In the absence of a syntax.
You're talking about appropriate use criteria?
Yeah. Will we have appropriate use criteria in the future, and how quantitative will they be?
Yeah, so the appropriate use criteria will be generated by the document. I assume that they're probably starting to work on that now, and it'll be generated by the document in terms of what's appropriate to do for revascularization. In revascularization appropriate use, there's really no discussion in prior documents about the use of the syntax score, because the appropriate use is about revascularization or not so much using a syntax score.
Yes, that committee's already been put together.
It's a challenge for me to believe that we're going to see more appropriate use in the absence of quantitative data assessing the complexity of coronary artery disease. I have that's a leap of faith that I'm reluctant to make.
Well, I think that the new document highlights that we all agree that this is a very complex problem, and identifying traditional and non-traditional contributions to how patients do highlight that Part Team will be helpful, and including the patient's perspective. It can't be simplified this much.
Well, listen, we have now well past the 90 minutes that we allocated to this conversation. I want to thank every one of our panelists and all of our attendees for a collegial, thorough, professional conversation that I think for the very most part was data-driven and evidence-based. We did not, as we expected, agree on everything, though we agreed to disagree on some things and to do so as colleagues and friends. And I think that that is the path forward for our profession. Thank you all for participating on behalf of the International Society for Coronary Artery Surgery. Have a great Saturday.
Thanks, John. It's
You
great.
all.
Thank you.
Thanks for having us.
Great time. Thank you.